Thank you, ASCO, for giving me this opportunity to present a randomized trial done in the north of England in the Leeds Cancer Centre. My name is Galina Velikova. I'm a medical oncologist and academic researcher, and I'm presenting on behalf of my collaborators a phase 3 randomized controlled trial of an eHealth intervention during chemotherapy. It's called eRAPID, Electronic Patient Self-Reporting of Adverse Events, Patient Information and Advice. Physical symptoms during cancer treatment are common and impact on patients' quality of life. They are due to the disease or adverse effects of treatment or toxicity. And often in clinical practice, it's not possible to say if the symptoms are due to disease or the treatment. So in this presentation, I'm using the umbrella term symptom reporting to indicate both disease and toxicity. Cancer treatment delivery is a balance between effectiveness and toxicity, and patient safety is dependent on the timely detection and management of that toxicity. Traditionally, clinicians evaluate symptoms using common toxicity criteria, but more recently, in the past few years, standardized questionnaires known as patient-reported outcomes have been recommended in cancer care and in clinical trials. There is increasing evidence that patient self-reporting of symptoms during their care brings benefits. This approach significantly improves clinician awareness of patient symptoms, symptom control and quality of life, use of emergency services, and survival in advanced cancers. The trials are predominantly done in metastatic cancers, and there were smaller studies in the curative setting. A different approach looking at patient education and supporting self-management also acknowledges positive benefits for symptom control. eRAPID intervention uniquely combines patient reporting with self-management advice. The aims of the randomized trial are to evaluate the eHealth intervention and more specifically to test the hypothesis that eRAPID, when added to usual care, improves symptom control, this is primary outcome, improves patient self-efficacy, quality of life, reduces hospital admissions, and is cost-effective. The trial design, we are recruiting patients starting chemotherapy for breast, gynecological, colorectal cancer, both with curative intent and in the metastatic setting. They are randomized 1-to-1 to usual care, and usual care in England consists of the acute oncology services, where all patients during treatment, if they have problems, they go directly to acute oncology admission unit and do not go to ER. They're also provided with 24/7 emergency hotline for advice. All patients receive senior nurse support during their treatment. eRAPID intervention was added to usual care, consists of weekly online monitoring over 18 weeks. Patients self-report symptoms and toxicity. They receive immediate advice on self-management or to contact the hospital, and reports are integrated in the medical records. Outcomes are measured at 6, 12, and 18 weeks. Primary outcome symptom control using FACT physical well-being scale, which covers a range of common cancer symptoms. Self-efficacy using LORIC 6-item scale, quality of life measures, cost effectiveness, EQ5D, and clinical process measures from the electronic records, hospital contacts, and admissions. Patient outcome measures were collected on paper and returned to the hospital. The next few slides will show details of eRAPID intervention. Patients log in via a website which contains information on general management of symptoms. Then they complete between 12 and 15 symptoms tailored to their cancer and the treatment. If they report severe symptoms and ongoing symptoms, they will receive advice to immediately contact the hospital and the acute oncology hotline, the text in red here. If they report mild and moderate symptoms, they will receive self-management advice at the end of the questionnaire. Clinicians can view patient records immediately in the electronic records, and an example of graphic format is presented here. We ask the clinicians to use the patient reports during the encounters, and we provided training via e-learning system. The methodology of the trial is on this slide. We estimated a sample size of 504 to detect 2-point difference in physical well-being. This is considered to be the minimal clinically important difference. Missing data from the paper outcome questionnaires was examined and multiple imputations were performed. We used as main analysis multivariable mixed effect repeated measures models. For clinical interpretation, we used descriptive responder analysis of change scores. Subgroup analysis was performed for non-metastatic and metastatic disease, and we examined patient adherence to online reporting. Recruitment and baseline characteristics are here. Over 3 years, all clinicians involved in patient care were engaged in the trial. We recruited 508 patients out of 690 eligible patients, having a good consent rate of 73.6%. 49 patients withdrew, 37 from eRAPID, 12 from usual care, and we had 10 deaths equally spread between the arms. The table presents the baseline characteristics, and I just wanted to draw your attention to the proportion of patients with early disease treated with curative intent, 62%. The rest were metastatic. Primary outcome analysis showed improved symptom control in eRAPID at 6 and 12 weeks, but not at 18 weeks. These are the results from multivariable mixed effect models, and the graph shows the mean scores in eRAPID, the red line, and usual care, showing better symptom control in eRAPID group. In the responder analysis, we calculated proportions of patients that deteriorated by 2 or more, or improved by 2 or more points on physical well-being scale. And you can see that a larger proportion of patients in eRAPID group had stable symptoms and less deterioration, and smaller proportion had deterioration than in the usual care group. Subgroup of analysis of non-metastatic group showed similar results, significant at 6 weeks, borderline at 12 weeks. But in the metastatic group, there was no statistically significant difference, although similar pattern of results was observed. From the secondary outcome, patient self-efficacy was an important outcome, as we included as active component immediate patient advice, and we were pleased to see improved self-efficacy with intervention effect shown here. The responder analysis using 1/3 of the standard deviation as minimal clinically important difference showed that larger proportion of eRAPID patients, 26%, had meaningful improvement in self-efficacy than usual care. We didn't see differences in cancer behavior inventory. In the secondary quality of life measures, we saw a better self-reported health on EQ visual analog scale at 12 and 18 weeks, but no significant differences in the other global quality of life measures. Concerns about increasing clinical workload are common with these regular monitoring projects. So these graphs present the cumulative number of oncology hotline calls and emergency admissions for the 2 groups. eRAPID is in red here, and statistical analysis doesn't show any significant difference between between the groups on those measures. We examined adherence to eRAPID intervention. We had over 3,000 online completions with median weekly completion rate of 72.2%. It was higher in week 2 and lower in week 18. The graph here shows the number of completions per patient, and you can see that the majority of patients were compliant, having 18 more or around 18 completions. Smaller number either actively dropped out or didn't comply and didn't fill in many reports. Adherence was associated with higher baseline FACT physical well-being scores, and importantly with clinicians' use of eRAPID reports based on clinicians' self-reports. Does it matter if patients are adherent or not? We did further exploratory analysis and found high weekly adherence was associated with better physical well-being outcome at 12 weeks. Activation of clinical algorithm is an important measure of the clinical workload and how good the intervention is. Despite concerns of increased clinical workload, only 1% of the 3,000 completions generated alert to clinicians and to patients to contact the hospital, and the majority, 82%, were generating self-management advice. You can see here the most common symptoms that patients reported. We performed a qualitative sub-study, which will be reported separately, but here are some themes from this sub-study showing patient feedback. Patients felt that intervention helped them to keep in touch with the hospital, gave them permission to contact the hospital and prompt them when to do that. They felt they were taking an active role in their treatment. They found the intervention helpful to medical staff, but data wasn't always used. Clinicians liked the graphical presentation and found them helpful as well. So in conclusion, online symptom monitoring with immediate patient advice improves symptom control early during chemotherapy. We showed benefits during adjuvant chemotherapy. This is the largest study showing this. We also showed improved patient self-efficacy without effect on healthcare utilization. And we examined cost effectiveness, which will be reported separately. Limitations should be acknowledged. This is a single center trial. And with the randomization one-to-one, clinicians were seeing patients in both groups. Therefore, there is a contamination bias possibility which will reduce the intervention effect. We didn't see effect in metastatic cancers in contrast with other trials. We don't fully understand that. Maybe it wasn't powered, or the mechanism of impact of intervention is more complex. Future directions, we think our study is sufficient to recommend routine use during adjuvant chemotherapy, certainly in English, in NHS. We recommend developing eRAPID for immunotherapy and oral targeted therapy. In our study, eRAPID was added to usual care, as at the time we didn't have enough information on benefits and safety of this approach. But going forward, it could be an important component in new models for cancer treatment delivery to reduce hospital attendances while still supporting and monitoring patients. This is pertinent in the current COVID-19 epidemic, and that was recognized by JCO Oncology Practice recent editorial. We need good models for monitoring patients whilst reducing their face-to-face contacts. This is a picture of me in my outpatient clinics in the last 2 months, when only a quarter to a third of the patients I saw face-to-face, you know, but even then patients couldn't recognize me, and majority of my contacts were telephone consultations. I would like to acknowledge funding by National Institute for Health Research for a 5-year program, which made this work possible. And I wish to thank the patients, oncologists, and clinic staff for supporting this work. And I'm very grateful to my research group delivering this study. Thank you very much for your attention.